Hello and welcome back to Obcast. Today we're going to talk about Pprom, which in Australia stands for preterm pre-labour rupture of membranes. So first of all, what is Pprom? We've said that is the rupture of the fetal membranes prior to 37 weeks and before the onset of labour. It complicates 2 to 4% of pregnancies and is actually even more common than this if there's a twin or a higher order of multiple gestation. And it can happen in any trimester, but it's most common in the third trimester. And it's a reason why we ask women antenatally if they've had any fluid loss, generally at most of their appointments. There's several risk factors for Pprom. The true pathogenesis isn't well understood, but it is associated with smokers, women with low BMI, cervical incompetence, and some other things that you can see there. Now, in terms of diagnosing Pprom, first of all, you need to have a index of suspicion, and therefore you need to ask some questions. Now, it is true that some women will present with a rush of fluid, but it can be, a little bit sneakier than that. So asking women about any fluid loss, and if they've had it, if it was malodorous, if they've got any associated uterine contractions or uterine irritability or fevers, and as well as general fetal well-being questions such as fetal movements. And then a general past medical and antenatal history are always important. It's diagnosed by a sterile speculum examination, and the goal of that speculum examination is to visualise the pooling of amniotic fluid in the lower part of the speculum, in the lower blade. This is best achieved if the woman is able to lie flat for 30 minutes just to allow the accumulation of fluid. But the speculum exam can achieve a couple of other things as well. It can screen for cord prolapse, which is a really important but rare complication of any ruptured membranes. You might be able to detect some early cervical changes associated with labour, and it can facilitate the taking of whole or vaginal swabs and evaluation for any signs of genital tract infection. It's important to say that digital vaginal examination is best avoided in these patients, as it increases the risk of infection that we'll talk about shortly. Now, an ultrasound and amniotic fluid index can be suggestive that there may be ruptured membranes, but it really isn't sufficiently sensitive to exclude it. And in some women where you're still not sure if they've ruptured their membranes or not, you can admit them essentially for pad checks to see if they've got ongoing fluid loss. And there's some commercial products that we'll talk about in a little bit. Now, the main differential for Pprom is urine leak, which becomes more common with advancing pregnancy, but it complicates sort of up to 20% of pregnancies. And urine leak what I mean is when a woman's unaware that she's had urine leak and thinks that it might be a ruptured membranes. So some other things that you can use to diagnose ruptured membranes if it's not obvious is if you get the fluid and put it under the microscope, it can appear to firm. There's a picture of that there. There's some pH-based tests such as the nitrazine test. So if the pH of the vaginal fluid and urine is generally acidic. So if you use the nitrazine strip and put some of the fluid on it and it turns blue, that suggests that it's more alkaline and is most likely to be amniotic fluid. There's a few false positives or reasons for the pH of the fluid to be a bit higher, and that's if the woman's got bacterial vaginosis or even trichomonas if they've had recent intercourse and there's semen or blood. There's some other commercial products. Now, the Alsense is a panty liner that operates on a pH basis similar to the nitrazine test, and it changes colour in the presence of amniotic fluid, or to be more specific, in the presence of alkaline fluid. There's the AmniSure test, and it actually is a monoclonal antibody test looking for placental alpha microglobulin 1. It's got quite impressive sensitivity and specificity, as well as the Pprom, which looks for insulin-like growth factor binding protein 1. These tests aren't cheap, and they're a very useful adjunct, and I think best used in the women where the diagnosis is still uncertain. Now, why is Pprom important? And that is it's associated with several important complications. Now, it's associated with increased perinatal mortality, and that is mostly due to its infection risk and likelihood of preterm birth. Some small old studies suggested that 50% of babies will deliver by 48 hours and 90% by 1 week. And so you can imagine the associated complications of prematurity that come depending on the gestation at which Pprom occurs. Cord prolapse is very important. This is an obstetric emergency. And it is, in some ways, more likely given in Pprom it's very unlikely the presenting part of the baby is well engaged. Chorioamnionitis or intrauterine infection is a really important complication of Pprom and one that you need to be very mindful of. Placental abruption, pulmonary hypoplasia, and this is because the amniotic fluid actually has a role in fetal lung development, and then when it's not present, that process is hindered. Limb positioning defects, just because there's less room in the womb for the baby to move around. And then probably unappreciated is that this can be a really horrible experience for women, not so much having ruptured their membranes, but more so the associated prolonged admissions, preterm birth and time in the neonatal intensive care unit, loss of income and difficulty with other childminding for partners and the family at whole, and in some cases, the adverse birth experience can even lead to things like post-traumatic stress. So I think underappreciated is the patient as a whole, but those things can be really important for families. Now, in terms of Pprom, and this is particularly for people who aren't working in birthing centres, you really need to ask yourself 4 quick questions. First of all, is there cord prolapse? And you're going to see this on a speculum examination. 2, is there fetal compromise? Now, under 28 weeks, you may as well just do a fetal heart rate, particularly if you're not in a more advanced birthing centre. But after that, a CTG would be the standard of fetal well-being assessment. Are there signs of established infection? Now, this is unlikely if the woman's just ruptured her membranes, but if you feel like it's been a bit more occult and it's happened in the last week or so, this is really crucial. And are there any signs of established or establishing labour? Because obviously that's going to change the priorities of the next interventions. Now, assuming that those 4 questions haven't yielded any immediate priorities, well, I thought we'd talk briefly about the management of Pprom and the principles around it. Now, I guess it's important to acknowledge that most of the listeners won't be in tertiary obstetric centres, and they might not even be in obstetric centres. It might be in emergency departments, general practice clinics, small hospitals. And it's important to remember that these are the kind of patients that you need to speak to your tertiary obstetric and neonatal unit about. So call for help, there's absolutely no shame in it, but we'll talk about some of the management principles now. So antenatal corticosteroids are used to help fetal lung maturity and also reduce the risk of intraventricular hemorrhage and some other complications of preterm birth. And the most common steroid we use is betamethasone, 11.4 milligrams intramuscularly in 2 doses. Dexamethasone is another option. The different states in Australia use different cutoffs for the administration of corticosteroids. It's probably well accepted to be given under 34, 35 weeks, but some states actually give it up to 36 to 37. Antibiotics. So for the first 2 days, these women are given intravenous benzoyl penicillin with lincomycin or clindamycin as an option for those penicillin allergic. And then after that, oral erythromycin for 10 days. This has been shown to reduce the incidence of chorioamnionitis and reduce and lengthen the time to delivery. And interestingly, there was a study with augmentin versus oral erythromycin last decade that showed increased risk of necrotizing enterocolitis with oral augmentin. So oral erythromycin is currently what's recommended. And in the setting that there is established or evidence of chorioamnionitis, then they're recommended antibiotics. So triple IV therapy with ampicillin, gentamicin, and metronidazole. Now, tocolysis is indicated if contractions are present, and oral nifedipine is the tocolytic agent of choice in most centres. And the goal of this is to essentially facilitate corticosteroid administration. So once that has occurred, and there's been around 24 hours since that dose, then tocolysis is no longer indicated. And in the setting of bleeding or infection, it's not indicated either. In the children under 30 weeks, we offer them neuroprotection with a magnesium sulfate infusion. Now, the dose there, as you can see, is the same as for severe preeclampsia or eclampsia. And this has been shown in a Cochrane review to reduce the incidence of cerebral palsy with a number needed to treat of around 63. And I'm not sure whether the benefit is higher in multiple pregnancies. There's been some suggestion of that. But neuroprotection is something to consider and something you might seek advice on in a smaller centre. It's important to counsel these women, and that involves talking to them about the possible complications that might occur and the plan that you're going to put in place to address and seek and treat those, as well as maybe involving the paediatric or neonatal service to get a better understanding of how a baby born early might need to be treated. And then there's always a discussion or consideration around delivery, and that might be either to let the pregnancy continue and labour when it occurs spontaneously, or to induce, and that's based on several factors such as the gestation of the baby, and over 36 weeks it's generally accepted to just induce these women, or other factors such as GBS status or presence of infection or fetal well-being, or all other considerations around the timing and mode of delivery. These women and babies are monitored, and usually they're in hospital for at least 72 hours, but often a week, and in some cases until delivery. Initially, it's important to assess fetal well-being once or twice daily with either a fetal heart rate or a CTG, depending on the gestation. And then also remembering clinical monitoring of signs of infection, so pad checks for malodorous discharge and fevers and uterine irritability. It's common practice to get daily and then twice weekly inflammatory markers with white cell count and C-reactive protein. It's unclear from the literature the true utility of this, but I guess it's concerning for infection if you have consecutive daily CRPs over 20 or a CRP that rises over 40, and that can be part of the picture that can help you make some delivery decisions, or at least help guide the treatment in the tertiary obstetric unit. A high vaginal swab or low vaginal swab in some centres is commonly done to help to guide antimicrobial therapy if chorioamnionitis develops, so that can be helpful as well. And as discussed, admission or transfer, which is often more appropriate. So that's the end of our discussion on Pprom. It's something that's not dealt with commonly in small hospitals or emergency departments or general practice clinics, but it's important to think about because it has quite significant implications for the pregnancy and the baby. That is all I have to say about Pprom, so thanks very much for listening to Obcast, and see you next time.